Okay. So you see my screen now. Okay. Dr. Omar, you see my screen? Okay. So,
Yes.
Professor, yes. Yes, we can see your screen. I was
yes,
just sorting
okay,
out my
thank you.
mic.
All right. So usually it is important to know that in the clinical stations or clinical base, like we called it in the whatever the college, we only have 4 topics and you have 3 stations. These 4 topics including head and neck station, and this is including thyroid, parotid, submandibular, cranial nerve examination, cerebellum, and swelling like lipoma. The most common coming for the last few years, maybe the last 5 years, is usually submandibular gland, and usually the patient is normal and have nothing. In the past, we have thyroid, but now we don't have much thyroid. Examination of cranial nerve, normal patient also can be done. So the common come in these stations is either submandibular or cranial nerve, and sometimes both. Abdominal examination just examines the abdomen or inguinal hernia, and usually no finding, and the patient is normal. In the vascular, we have lower limb ischemia, we have varicose vein, we have EV fistula. And whatever the station, you need to use how to use the handhold Doppler. After that, we have orthopedic station and contain spine, hip, knee, and foot. This is the clinical cases you can find in exam. Some students have the belief that we have examined the chest or examined the cardiovascular, and actually we don't have cardiovascular examination or chest examination. This is if come to an exam, it is part from pre or post-operative assessment of the patient, and it is under applied surgical science, which included under surgical physiology or critical care. And this situation is not a station of examination. So you need to take a quick history about respiratory system. You need to examine the chest of the patient. You need to look in for the investigation. So it is like pre-clinic admission or how to examine the patient, but not a clinical examination station alone. So we don't have clinical examination station alone for chest or cardiovascular. So this is very, very, very important. Okay. I will start first by examination, for example, head and neck. So if you start by head and neck,
اللي فيها بتاعت اللف بتاع المطوي بتاعها محلول. مطوي اللف محلول. قلت له ماشي خيط. شوفوا لي بس عامله كام؟ وحنا عامله 250 هي ب 250 تأكيد. ماشي؟ ماشي. هو هي بيعملها هو.
So in the neck examination, what we have, we start first by the swelling. So you can have a script like this. 45 years old man presented with anterior neck swelling, several years duration. Make focal examination or focus examination, describe the finding as you proceed. The examiner asks you some question. We have some debate about some student, he don't speak during examination. It is better during examination, especially in the neck, to tell what you examine. You examine the lymph node, you examine the thyroid gland, what you examine. So you see carotid pulsation. So it is important to tell the examiner what you are doing. Of course, we have swelling like this. Sometimes no swelling at all. The patient is normal. You need to first, of course, after you introduce yourself, you wash your hand, you ask the patient permission, exposure. So you need to expose all this area in the front of the chest. Of course, even the patient, if wear hijab or cover a scarf, you need to remove it because sometimes the thyroid tumor can spread in the scalp. So after that, you buy inspection, you say the exact site, size, shape, surface. It is important to ask first about movement of the swallowing because this is indicates that it is thyroid swelling. So from the beginning, you need to ask the patient if it is move up and down with swallowing, and also give him sips of water. Ask him don't to swallow except after watching, and you can find this swelling move up and down. So this is done during inspection. After that, in palpation, before you touch the patient, you ask permission. Is any pain? So patient say no pain, or I have some pain. If the patient say I have some pain, so just tell him I will try to be gentle. After that, you can start like looking the size, the shape, the surface again. It's important to see the lower border because it is indicate that if it is not reach the lower border, so it is retrosternal extension, confirmed by percussion in the menobrium. You're looking for the site again, confirm the surface, the border, consistency. After that, you examine the trachea. So looking for the trachea is central or not. And again, usually if you have swelling in left side, so trachea most probably deviated to the other side. If the patient have bilateral swelling, so the trachea is central. After that, you need to examine the carotid artery. Carotid artery examine one by one, not two in the same time to avoid ischemia to the brain. Of course, it is important to examine the lymph node. Again, lymph node, when you examine the lymph node, don't say, because we see in some exam that some patients or some students say, I will examine your gland. Lymph node is not a gland. It is not a glandular tissue at all. It is difficult or something translation from other language. So lymph node is a lymph node, is not a gland. So don't tell the patient, I will examine your gland. If you need to speak in English to the patient, I will examine your lymph node. Not, I will examine your gland. It is not a gland. So you can find, of course, you don't find huge swelling like this, but it is bilateral swelling, can be right and left or from the isthmus and the left side. After that, you make a percussion on the menobrium to exclude retrosternal extension. You need to auscultate, so if we in toxic case, and usually we have nothing. So what again you make it? So you make inspection, ask the patient to swallow or drink water. You palpate after the patient permission. You examine the size, the shape. You looking for the border, surface, smooth or irregular. Attach it to the skin and the muscle is very important. Skin because of the cancer, and the muscle if infiltrates the muscle. After that, examine the carotid arteries, examine the lymph node, examine the trachea, and once you finish inspection, palpation, percussion, auscultation, don't forget to do thyroid status. Thyroid status, you mean that you're looking for the patient pulse, usually chart beside the patient. You're looking for the vital sign of the patient. You ask the patient, you hold his hand to see it is warm. Is any fine tremors? Ask the patient to see any fine tremor. You can put a paper. And after that, you're looking for the eye manifestation. In the eye manifestation, you looking for the movement of the eye. Ask the patient to look up to the ceilings. You can find frontal wrinkling. Ask the patient to go to down looking for lead leg. So in this station, you have inspection, you have palpation, you have percussion, you have auscultation, and the item we tested, you need, apart from the swelling, you need to examine the trachea, carotid pulsation, lymph node, attach it to the skin and the muscle. After that, or before that, thyroid status. So what is the most likely diagnosis? Either the patient is normal, just normal. If have a swelling, so can be goiter. It is toxic, non-toxic, according to the examination or pulse. So usually is non-toxic. Suppose the patient is toxic, usually he take treatment. So the patient tell you, I have this treatment, I take propranolol, I take antithyroid drug. So it is toxic, but is controlled because under treatment. Okay. So when you ask if you take a history, if you need to take a history, if not an examination station, and you need to take a history, suppose it is history station, so you need to ask about dysphagia, dyspnea, hoarseness of voice. You need to ask about toxic manifestation like nervous, irritable, fine tremor, myopathy, menstrual disturbance in female, GIT disturbance, eye manifestation. In some patient, if it is hypothyroid, so you're looking for the apathy and the loss of hair in the eyebrow. So this is usually maybe come after you finish, after 60 minutes. So maybe the examiner ask you some question related to theory. Okay. Of course, you can find some patient have proptosis. investigation you will did if you ask just like baseline investigation followed by thyroid function test including T3, T4, TSH, and neck ultrasound. The value of neck ultrasound is to know it is the site of the swelling, it is cystic, it is solid, and if it is cystic, we will do fine needle aspirated cytology and send it for histopathology. And also to examine, to looking for the lymph node. In this situation, he asks you, I can ask you, any one of you, so which thyroid tumor is spread by lymphatic? Which thyroid tumor can be spread by lymphatic? Anyone have an idea?
Papillary thyroid tumor.
Yeah, papillary thyroid. What age papillary thyroid tumor usually presented?
20 to 30.
20 to 30. Although cancer is common in old age, but papillary thyroid carcinoma is the only thyroid tumor can occur in young age, and it is multifocal. So usually we recommend the total thyroidectomy for it. Okay. Of course, you have papillary, follicular, anaplastic medullary. I don't consider lymphoma is a thyroid tumor because lymphoma is occur in the top of Hashimoto thyroiditis, so it is not a proper thyroid tumor. We have papillary spread by lymphatic, follicular spread by blood, anaplastic and medullary can be spread by different methods and occur in old age. Papillary occur from 20 to 30. Of course, they can occur in old people also, but common can occur in age of 20. All these tumor, only one tumor have a tumor marker. So which tumor of thyroid tumor have a tumor marker? Anyone?
Medullary.
Medullary, and the tumor marker is?
Calcitonin.
Calcitonin. So it is important. The only tumor marker here is calcitonin. We have some tumor marker non-specific like thyroglobin, but it is not specific for any particular tumor, but calcitonin is the medullary thyroid tumor. If the patient say, many of my family have the thyroid cancer, and it is medullary. So what you expected? What disease syndrome can cause this?
Type 2 syndrome.
Okay. Okay, so multiple endocrine neoplasm type 2 is characterized by pheochromocytomas, characterized by medullary thyroid carcinoma and parathyroid adenoma. And the next question, usually, if the pheochromocytoma, what is the tumor marker?
Vinyl mandelic acid in the urine and catecholamines in
the blood.
in the plasma.
In the blood, okay. Metformins or metaepinephrines in the blood and phenyl mandelic acid in the urine. Okay, so this is the same what happened in the exam. Usually in Malaysia, maybe in other country, we don't ask this, but we ask about this is the typical picture of which cancer. Is doctor from Malaysia? I think you know the answer. What you think is this type of
Papillary.
cancer? Say again?
Papillary cancer.
Papillary.
Samoma body.
And what? Yes. So this samoma body or macrocalcification, and usually we call this picture is orphan Annie cell. Is look like empty, is actually not empty, but it is called orphan Annie cell. It is characteristic of the papillary thyroid carcinoma. Again, this is multiple endocrine neoplasm. We have parathyroid adenoma, pancreatic adenoma, pituitary adenoma in men 1, so it is not important to us. What is important is type 2, have medullary thyroid carcinoma, pheochromocytoma, parathyroid adenoma, sometimes can neuroma or morphonoid picture. Okay? Of course, this patient is common picture in belly and love or Hampton belly. The patient have a swelling, and this swelling is not move up and down with the swallowing. And after excision of this swelling, they found it is just lipoma. Okay, but we don't have complicated case like this in exam. It is just for teaching. Okay, so as you see now, it is easy. So you have 6 minutes to examine the patient, and you have 3 minutes for question. Usually question, what's your diagnosis, what's the investigation, and how to manage. Just 3 questions. It is important to know the investigation start by full blood count and specific investigation like in thyroid case here. So you need to have T3, T4, or TSH. Okay. All right. Second case in the clinical examinations, you can find it. is in the neck is the parotid gland and submandibular. I start by parotid, is not take a time. Of course, again, nowadays, most of the cases appear in exam is normal case, no finding. We just tell you the patient have a swelling and suddenly disappear. So it is the same script. So 35 years old man is depend on the patient have left parotid swelling, disappear today. Disappear means that it is inflamed and disappear. He just explanation why the patient have no. So usually parotid area in front of tragus can be painful. Usually any swelling in parotid is painful. This is look like abscess. It is important when you examine inspection for both sides. Of course, you introduce yourself, you explain to the patient, you wash your hand, but inspection both sides, right and left. After that, you ask the patient to clench his teeth. So clench his teeth, contraction of masseter muscle can make the parotid swelling more prominent, and usually also is not apparent any thyroid swelling, any parotid swelling. After that, go to palpation. Before you touch the patient, you have any pain, no pain, okay, you touch the patient. Some patients say, yes, I have some pain, so just tell him, I will try to be gentle. Some students have a special strange attitude. Suppose the patient have painful in the left side, he examines the other side. So it is not logic for exam. Okay? So by palpations, you examine, it is hot, not tender, skin, no swelling, normal surface of the skin. Ask the patient again to clench his teeth, so no apparent swelling. And after that, you ask the patient to open his mouth to examine the parotid duct. When you examine the parotid duct, you say it is in the upper second premolar, and usually examiner asks you which muscle is pierced by the parotid duct, and what is your answer? Anyone?
masseter muscle.
No, it is vaccinator muscle.
Vaccinator.
And the next question, what is the nerve supply of vaccinator is?
Facial.
Facial nerve. Okay, so parotid duct pierces vaccinator muscle. Vaccinator muscle is supplied by facial nerve. Okay, if you miss, examine the neck. Examine the neck lymph node is very, very, very important. Any neck swelling, you need to examine the neck lymph nodes. Examination of neck lymph node, of course, from the back. Any other area, so usually if you miss, so the examiner asks you, is any other area you need to examine? So if the examiner asks you in any swelling, any other area you need to examine, so it means that you miss the lymph node. If you miss the lymph node have a big mark, because usually it is half for the swelling, if you have a swelling and the lymph node. It is important when you examine the lymph node just to enumerate submental, submandibular, post-auricular, occipital, upper, lower, deep cervical lymph node. Okay. This is, you open the mouth. It is important also in the parotid and submandibular, you examine the mouth because most of the pathology in the salivary gland due to bad oral hygiene or dental caries. So you need to examine the mouth. And you put tongue depressor because the duct in the vestibule, so the duct is up. Examine the lymph node from the back and enumerate the lymph node. And again, this is the lymph node, submental, submandibular, post-auricular, upper, lower, deep cervical. It is better to tilt the head, tell your direction. If you need to examine the right side, tilt it to the right side. Okay. I think Dr. Rami asked, do I mention the name of cervical lymph node while palpating? Yes, it is better. You know that in other station, don't need to mention something, but especially in the neck, I usually examine the head and the neck. So we don't know what you are doing. Suppose you put your hand here, for example. I don't know what you palpate. Maybe palpate the submandibular gland. Maybe palpate the lymph node, maybe palpate the carotid. So you need to tell me. So it is important if you have debate to tell I examine the lymph node, it is submental, submandibular, so it is better to speak. But don't say, for example, you palpate the liver, so don't say I palpate the liver. Says no, that the right side is the liver, left side is spleen. So it is not need to tell them or the examiner you palpate the liver or the spleen. It is, or I auscultate, so it is notice that you are auscultating. In some ENT, they divide it to 5 layers or 5 area. We don't ask you about this except if you are ENT, but we don't ask you this in exam. Don't forget, after you examine the fascia, the parotid, you need to examine the facial nerve. So examination of facial is very important. Of course, facial nerve have temporal, zygomatic, buccal, mandibular, cervical branch. So 1, 2, 3, 4, 5. It is important, of course, if deviation of something, so it is indicated that they have lower motor facial. Usually we ask you in this station or cranial nerve station how to differentiate between upper and lower motor facial. Of course, if the patient able to elevate eyebrow and close his eye, so it means that it is upper motor neuron lesion. But if the patient, which is like parotid patient, if they have something affects the facial nerve, so they unable to elevate eyebrow and close the eye in the same side. But the rest of the face is the same. Of course, the cause of facial paralysis in the parotid usually can be iatrogenic after parotid surgery or due to cancer in the parotid gland, and the common cancer can cause affection of the facial nerve is adenocystic adenocarcinoma of the parotid. Okay, so you can find facial policy like this. And to differentiate, so if the patient able to elevate his eyebrow and close his eye, so it is upper motor. If unable, so it is lower motor. Okay. So this is the very common question. After that, the examiner asks you again, if you don't mention, like where you looking for parotid duct in second upper molar teeth, piercing which muscle, vaccinator muscle, nerve supply is facial. Usually we ask this question, what is the other muscle supplied by facial? So it is important to know that all muscle of facial expression, of course, include platysma, stylohyoid muscle, stapedius muscle, posterior belly of the gastric. So 2 by S and P. How to identify facial nerve during surgery in UK, because maybe in your country they don't do that, but in UK and the other most of the country nowadays, to identify the facial nerve during surgery by nerve simulator. The same also done nowadays for recurrent laryngeal nerve in the thyroid, we use nerve simulator. Okay. What is the cause if the patient have bilateral parotid swelling? So usually it is infections like mumps in baby or children. In some patient maybe sarcoidosis. Usually he asks you, why you ask the patient to clench his teeth to contract the masseter muscle, because the parotid gland is superficial to the muscle. How to differentiate between upper and lower motor? So in upper, the patient can elevate eyebrow, close his eye on both sides, but in lower, he can't in the same side. Again, the common cause for lower motor neuron is damage of the facial nerve due to surgery or due to tumor in the parotid gland. The common cancer, of course, all cancer can cause, but the commonest is adenocystic because characterized by neurolimmal sheath spread. So adenocystic carcinoma. Again, this mumps is bilateral, usually in baby. Most of the country have vaccination against mumps, so you don't see it nowadays. In UK, they don't give vaccination against mumps, so you can find the cases in UK if you work in UK in the future. So this is as regard parotid. Any question till now about parotid, by the way, or about the thyroid?
Doctor,
Yes.
about the parotid gland.
Yes.
If the patient is normal patient, how we can describe the tumor during
No,
the
you don't
examination?
imagine. You don't imagine. You just say no swelling, his skin is normal. I ask him to clench his teeth, so nothing appear. You don't imagine, because we found some student, he imagine. He say, we have a swelling, so you don't imagine in the exam.
Mm-hmm.
Okay,
So
just to
start,
say
there is
it
no
is normal,
swelling.
no swelling. Say again.
They say no swelling, no
No swelling,
skin
normal
scars,
skin, no dilated
no
vein, no
any
apparent
changes.
scar, all this.
After that, start palpation.
Inspection, palpation, yes. After that, you palpate the duct. Usually, I don't prefer to do by manual palpation for parotid duct because parotid duct stone is very, very, very rare. So you can do it in submandibular, but parotid is not logic because it's
So
very.
we start first by palpate the parotid itself.
Yeah, you start by inspection and examine the parotid gland like this. After that, you palpate the duct. Or
And then
look
the
for the
cervical
duct. It's not
lymph node.
palpated. You're looking for the duct in the upper second molar teeth.
Okay.
You have tongue depressor to elevate the upper lip, and you have a torch or light source to see it.
Okay.
All right. Okay. I see is any question. So how can by manual parotid examination don't need to do that? Because first it is impossible to palpate the parotid duct by manually. It is very, very rare to find the stone parotid duct is not logic. So we don't need to make something unnecessary. I know that most our other courses or other books they write about this, but it's not logic. Why you ask to clench the teeth? You clench the teeth to contract the masseter. If you contract the masseter, parotid is superficial to the masseter muscle. So if you have a small swelling or tumor in the parotid, become prominent. It is common in the past. People have liver cirrhosis. They have what some called it in Egypt endemic parotitis. So you can find the big swelling like this, a small swelling, but become prominent with clenched your teeth. Don't twice to do by manual examination for parotid. Although I know that most of the students do that, but it is not. We don't have a score for that. After that, submandibular. Yes.
While inspecting parotid gland, should I inspect the duct from inside the mouth?
Yes, parotid duct, respect the parotid duct from inside the mouth, from the vestibule, the upper part of the mouth. So you put tongue depressor and the light source. You inspect it, but not palpated. Palpation is by manual. You put your finger from outside and inside, and it is impossible to palpate it.
So I shouldn't wear gloves while inspection and palpation of parotid gland.
Inspection, no, but in palpation, because you palpate the duct, it's better, yes, to wear gloves.
So I palpate the duct or not?
Not palpate, you inspect the duct, but to inspect the duct, you need to put tongue depressor and light source.
Oh, yes.
Okay. If you palpate the duct, you don't feel the duct, so don't do something is unnecessary. All right. After that, we have submandibular. Submandibular is very common. It's usually in every exam, although the patient is normal, and also gives the same scenario. This patient have swelling and suddenly disappear. Just to give the impression it is like infection or something. They usually tell you examine the left side or right side. Just don't to concentrate in one side. But after that, examiner asks you some question. Of course, we don't have something like this in exam, but if you have swelling in exam or you have a chance to ask the patient, even if you don't have the swelling, if you allow to ask the patient, we allow you to ask one question about pain. What is the second question we can allow you to ask about in the submandibular?
Sensation.
No, we ask him about if you drink something sour like lemon or soya or vinegar, if this swelling is increasing or not. Usually the patient yes says it is increasing with sour or with lemon. So it means that you have something in salivary gland. So we start first by inspection. So by inspection, if the patient is normal, so look in right side, left side, no apparent swelling, no apparent scar, no dilated vein in the right and the left submandibular region. Of course, if you found swelling, you can mention the swelling like site, size, shape, surface, everything. After that, you go to palpation from outside and inside. So if you go to palpation from here, so you palpate, so it's not hot, not tender, no swelling. If no swelling, if you have swelling, so you need to examine the swelling and the edge and everything. And usually in the whole station, in this station, you don't have swelling. So just by palpating the area, I don't found any swelling. After that, you wear the gloves. You can wear one pair of the gloves, no problem. So just put your hand, so one hand inside the mouse, one hand outside of the mouse, and you palpate the gland. In this situation, the examiner asks you, we don't found anything, but suppose you feel something by the outer hand, so what it could be? What is your answer? Anyone? If you feel the
Could
swelling by
be
outer hand, it is what?
could be the submandibular gland or lymph node.
No, if it is palpated from inside, it will be the gland. If palpated
The
from
gland.
outside, it is the lymph node. This is the value of bimanual. So you have one hand outside. If you feel it from outside and rolled against the mandible, so it is the lymph node. If you feel it from inside more, so it is salivary gland. Okay?
But
And
Professor, isn't the superficial part of the gland also palpable from the outside?
if it is bigger, if it is swelling, can, but it is difficult to roll, to roll against the mandible. But in normal people, you don't feel it.
Okay,
Yeah.
thank you.
So you make it by manual examination like this. After you finish this by manual examination, again, you can do like this. You need to put the torch again, tongue depressor again, ask the patient to elevate his tongue, looking for the duct in the frenum of the tongue, right and left side. Okay, after that, looking for any dental caries. So you can find the duct here and any dental caries, any problem. So here inside the mouse, you have two things you did by manual examination and inspection. You can did inspection first, inspection from inside by tongue depressor and light source, and after that by manual. So you examine from outside, examine from inside, inspection. So inspection from outside, inside, palpation from outside, by manual palpation of the gland from inside and outside. Okay, and to explain to him, if I feel it more from inside the mouth, it's salivary gland, from outside rolled, it is lymph node. Usually lymph node is not single, can be multiple lymph node. And if it is in the gland, I ask the patient if it is increasing with sour and lemon or something like that. After that, don't forget to examine what? Lymph node. Of course, you examine for dental caries, which is common. After that, examine the lymph node, neck lymph node. Again, it is neck lymph node, not a gland. It's not a glandular tissue. It is mistranslation, I think. All right. Again, you enumerate the lymph nodes, submental, submandibular, pre, post-auricular, upper, deep cervical lymph nodes. So you inspect, palpate by manual. Again, if you miss to examine the lymph nodes, the examiner asks you any area you need to examine. Neck lymph node examination. Okay, no need, because we found most of the student ask the patient, can you, they ask him, protrude your tongue and put something and ask for sensation of the tongue. It is wrong. Some student ask the patient, can you move the tongue looking for hypoglossus? Also wrong. Ask the patient about the angle of the mouth and blow your teeth or blow your mouth. It is also wrong. Why is wrong? Anyone have an answer? Why it is not part of the submandibular gland examination?
Because it is after injury, as
After
surgical
surgery.
mandibular.
Because if you injure it during surgery, if you injure the marginal mandibular, so it is post-operative, not pre-operative. Hypoglossal also can be injured in deep dissection of the gland, but not common. Lingual can be injured during surgery. Even if the patient have malignant tumor, is not affect all this nerve. Although it is rare malignant tumor, so if you did, which is common to be done, lingual, hypoglossal, marginal mandibular, we don't have mark for this simply because it is occur post-operative and this patient is either normal or pre-operative. So if you did it, it is extra work. You lost your time and no mark for that. Of course, bad habit, he protrude your tongue and make a like this and ask. It is not a test for sensation. Test of the sensation can be for pain and temperature and food. So it is not, if you need to test it, just ask the patient is the sensation is okay or something like that. So don't do that because this is can you lost at the time. Okay, again, this is the duct, this is the relation to lingual nerve. And we usually, if you have a stone in the duct, so the next question usually is they ask you about this. What's your diagnosis? So most probably this patient have nothing, maybe have salidinitis and improved now. Where is the opening of the duct? It is lateral to frenulum of the tongue. What is investigation? You be done either panoramic X-ray, ultrasound scan. We don't do nowadays salogram. We don't do endoscopy, although it is mentioned by most of the students. Endoscopy is not common use in this practice because people who deal with the submandibular duct stone is a dentist, not the ENT, not general surgeon. So they usually he give local anesthesia around the duct, opens the duct, and remove the stone. So we don't use endoscopy, although it is mentioned by many students. We don't do salogram, barium enema, all this is historical now. What you need to know if have a stone or not, we have panoramic X-ray, and now we have a small machine called CT for the mandible alone. It is special small machine for that. The management is conservative of the stone in the duct, open the duct, leave it open after local anesthesia, and remove the stone and don't close the duct. But if the stone in the gland itself, remove the gland through the incision from outside. So this is the duct, this salogram, we don't do it. See, this is the stone in the duct. So maybe if you are in exam and he asks you if you need to remove the submandibular salivary gland. So where is the site of incision for submandibular salivary gland? Where is the site of incision? Anyone?
2 cm below the
All right.
mandible.
Yes, Dr. Asma, this is 2 cm is the old guideline. It is maybe
4
5 years
cm.
ago.
4
Why?
cm.
Because if you make it 2 cm, you can easy to be injured marginal mandibular and the patient have drooling or have affection the angle of the mouth. So what we do nowadays, 4 centimeter or 5 centimeter, which is equal 2 inch below the angle of the mandible. Although it is not cosmetic and it is appear in the neck, but we to save because deformity in the face is not good. So nowadays we don't use the old. If you have old book, it is 2 centimeter. Now it is 5 centimeter. You got the point, Dr. Asma?
Yes.
Okay.
Thank you.
So just again, we need to know the submandibular is very, very, very common clinical case. And again, you go to by inspection and say nothing. You inspect from inside. You make by manual examination. You examine the duct, looking for the teeth. And after that, don't forget to examine the lymph node. After that, you have 3 minutes and the examiner asks you how to manage and what is the investigation. Again, the investigation either panoramic X-ray, ultrasound. We don't use salogram. We don't use endoscopy. We don't remove the stone in the duct by endoscopy. So it is just, we give the patient plenty of fluid, if infected antibiotic. If it's big stone in the duct, to open the duct, leave it open. If it is in the gland, remove the gland. Okay? Easy. Submandibular is very, very, very common. Maybe for the last exam, even the last exam, I think in Cairo, they have it. So it is very common station all over the world. Okay, easy, simple, don't take a time. And again, we don't need to examine the other cranial nerve or anything else. Okay. So this is as regards the neck. After that, we have cranial nerve examination. Cranial nerve examination is one of the fixed station for the last few years. And I just see if anyone asks some question. It is normal to finish examination of the neck swelling like submandibular before the 6 minute. Yes. Submandibular examination from the front. Then we move behind to examine the lymph node. Yes, usually it is from front. You are not direct front. It is just you are lateral because this is lateral. So you go to the lateral side of the patient. After that, you go to the back to examine the lymph node. Okay. Of course, you don't need to tell the examiner, I go to the back to examine the lymph node. He understands. Okay. Any question before we move to cranial nerve? So submandibular, again, it is expected to come in exam. It don't take a time, just easy, simple. And again, we advise the people who wear a glove, don't put alcohol before wearing a glove, because if you put alcohol before wearing the glove, it is difficult to wear it. So you don't use alcohol if you need to wear a gloves. Okay, after that, we have cranial nerve. Cranial nerve is very fixed station. It is important to know what is the aim of the examination of cranial nerve in exam. Anyone know why we put this station in exam? Especially anyone from who's not entered the exam know why we have this station.
It's a very long station, so it needs a lot of time management.
Yes, so the aim of this station is to have to manage time. You know that if you apply in job or apply anything, so every station in exam has special policy. So to examine 12 cranial nerve in 6 minutes, it is impossible. But you try to finish. So the aim of this station, how to manage the time. So suppose, which is common, especially if it is the first time you enter the exam, you don't finish in the 6 minutes. Maybe the examiner give you 1 minute or something. So don't be upset if you don't finish, because this is happened for all students. So this is just to see how to manage the time and what is your stress if you don't finish. So don't worry about this. So you need to put in your mind, so the cranial nerve, usually they give you many instructions. But if you read the instruction, may be different from time to time, but you can find. The task of this station to examine cranial nerve in a patient who is complaining of headache or visual disturbance. So you must put something related just why you examine the patient. Headache, loss of smell, anything. You don't need to test the sense of smell. If he asks, don't need to tell the sense of smell, but still you can ask. If you have any problem with smell, you can ask. Why we mention this? Because some of students, they have alcohol beside, he put alcohol and asks the patient to smell the alcohol, which is not practical. So we ask you, don't test don't do the test for the smell. Visual acuity, don't do visual acuity. Why? Because you don't do visual acuity, but if you have Snell chart, as you can see here, you just ask what is this? It is E, it is C, whatever, but you don't make it all the line, because we don't need to make glasses or to see the visual acuity, but just this patient is seeing. Of course, don't touch the cornea, no need for jaw reflex, no need for color vision, no need for gut reflex. Okay, so all this is not needed. So it's written directly, not needed. Of course, if endoscope is not needed, but you can find in the table, because sometimes the student use it as a light source, but we have a light source. Don't use pen prick to test the sensation. So you need to test the sensation. We have cotton, so you can use cotton. In some center, like in Malaysia, they have something called monofilament. Maybe not available in many countries. This monofilament is very tiny and it is non-traumatic. It's not a needle. After 6 minutes, so they ask you to present your finding. Okay? The station physical examination, not a history taken. So you don't speak much with the patient, is not a history taken. Okay, so it is clear. Before you start, it is clear. It is, we manage how to manage the time. It is 12 cranial nerve we need to examine in 6 minutes, which is very difficult. We don't need to give something to patient to smell, but you can ask. We don't need to see the whole line of the Snellen chart, so just 1 or 2 line, because we don't make eyeglasses for the patient. All right? If you find something unnecessary, you don't need to do that. So we can start one by one. So what you do first, introduce yourself. Good morning. Of course, this is the name of the cranial nerve. So start first by looking for vision of the patient. Can you see this nail chart? Usually it is in the wall. Yes, can you tell me what is the first line? So it is, for example, E, second line is F and P. So good. After that, you have a light source. You're looking for the pupil. You're looking for the pupil reflex. You can put your hand like this and put the light source here and looking for the other, what's called consequal, and looking for the pupil reflex. After that, no need for color vision. After that, you can do eye movement like H-shape eye movement. You can make it one by one or two together. If you find any difficulty, you make it one by one. After that, you difficult to looking for nystagmus, but what is important, visual field. So what you're looking for visual field, ask the patient close, you close the same eye, you see my hand, no, in the middle he see. So usually is the common scenario is the patient have something called bitemporal hemianopia. So he's not see except like tube vision. So again, you just ask about pupil, visual acuity, accommodation, eye movement, and field of vision. Visual field is very important because most of the cases have bitemporal hemianopia. Of course, it is not a real patient. He mimic bitemporal hemianopia. Okay, so looking for eye movement, H-shape picture. Of course, you don't have a lesion, but just remember the oculomotor nerve patient have dropping of eyelid, mydriasis, and down and the lateral gaze. Of course, what you test by this, you test oculomotor, trochlear, abducent nerve, and of course, optic nerve. So 2, 3, 4, and 6. So we still have 5. 5 is trigeminal. So in trigeminal, you can find a piece of cotton. So just to make it, you feel this like this like this, this like this like this. So this trigeminal, sensory. After that, you need to test the trigeminal motor. So test it motor. So this is the sensation. After that, you tested motor, so you can clench your teeth, masseter muscle. You can see the temporalis muscles. You can ask him to open his mouth, move his mouth. So this is for pterygoid muscle, masseter muscle, temporalis muscle. Okay, so now you examine 2, you examine 3, 4, 5, 6. So after that, we have 7 facial. So you're looking for facial nerve, sensory, and motor. Usually motor. The motor, so you ask the patient, started by eyebrow, ask to elevate eyebrow, close his eye, pull his mouth, and can clench the neck, show your teeth. So this is all muscle supplied by facial nerve. Of course, after that, at the end, he asks you this is a common question. What other, apart from facial expression and the platysma, so don't forget posterior belly of the gastric, stylohyoid, stapedius, and the stapedius in the middle ear to prevent high-pitched voice or to protect the ear from very high noise. Of course, also in the question, but not at time of examination, he asks you how to differentiate between upper and motor facial. After that, you have tongue depressor and the light source. Open the mouth, looking for uvula. This is a step. No, usually student take 0 in this step. You know why they take 0? What's the mistake, common mistake if you open the mouth looking for uvula? What you need to do? to make these positions, what you need to do?
Tell the patient to
Use
say
a torch and tongue depressor.
Okay, so what happened usually to see the uvula, you need to have a torch and tongue depressor. So what happened, many of the students just put light source, open your mouth and he's away from the patient. Of course, it is impossible to see the uvula. So it is important in exam. If you suppose this is exam is acting like you acting in exam, which is common cause of failure that you go to the exam like acting like make a movie. So this is a very, very, very bad habit, and this is can cause easy to fail. So if you need to examine uvula, open the mouth, put tongue depressor, put the light source. Okay, looking for uvula. Of course, if deviated to the other side, if they have glossopharyngeal or vagus affection. Of course, movement of trapezius, sternocleidomastoid is easy. Trapezius, can you shrug your shoulder? And sternomastoid, push my hand in this position, It is important, don't speak much English, just to tell the patient can do that, just to be easy for him and for you. After that, ask the patient to protrude his tongue. So, of course, looking for hypoglossal nerve. If they have a lesion, so the tongue deviated to the other side, to the same side. Okay? Or you can have some atrophy of the muscle of the tongue. Okay? Now you finish. Okay? Now you finish. So, it's supposed to be take 6 minutes. So, what is the question of examiner? He said, what you think, what this patient have? So if the patient have bitemporal hemanopia, so your answer is pituitary adenoma. Is anyone is pituitary adenoma is benign or malignant tumor?
Adenoma
What
means
do you think? Benign or
adenoma.
malignant?
Benign.
Benign. It is benign tumor. Although it is benign, but he is compressed on the optic chiasma and caused by temporal hemanopia. So this is the first question. So how to diagnose a pituitary adenoma by MRI or CT? Okay. How to remove the pituitary adenoma? You remove it transsphenoidal through here, through the nose or through the mouth. No need to mention causa, because if you mention causa is the ultrasound waves or gamma knife or all this, because it is not common to be used for this pituitary adenoma. So transsphenoidal approach is the easy approach. So don't give extra knowledge or something for examiner. You can find it is not logic or not common use. Okay. After that, he asks you again the muscle supplied by facial nerves, all muscle of facial expression, posterior belly, digastric, stylohyoid, trapezius. After that, he asks how to differentiate between upper and lower motor. Again, if the patient able to elevate his eyebrow, close his eye, so it is upper. If it is unable in the same side to elevate eyebrow and close the eye in the same side, it is lower motor neuron lesion. After that, if they have uvula deviated to the left side, so the lesion in the right vagus or glossopharyngeal nerve. After that, spinal accessory, if the tongue deviated to the left side, so the lesion in the left side of the hypoglossal nerve. Okay. It is important to know that all muscle of the tongue supplied by hypoglossal except one muscle, palatoglossal, supplied by
Glossopharyngeal.
no vagus. Glossopharyngeal supply only one muscle, stylopharyngeus muscle. So all muscle of the tongue supplied by hypoglossal except palatoglossal supplied by vagus. Sometimes, if you have a skull or in anatomy, they ask about the styloid process, and the three muscle arise from styloid process. Stylohyoid supplied by facial. Stylopharyngeus is the only muscle supplied by glossopharyngeal nerve, and styloglossal by hypoglossal. Of course, glossopharyngeal supply only one muscle, stylopharyngeus, and the back of the tongue, pain, temperature, and taste. Anterior third of the tongue, pain, temperature by lingual nerve, and taste by chorda tympani. Okay, cranial nerve is very, very common. If you are first time enter the exam, you don't finish, don't be upset. Usually, 6 minutes because they tell you 6 minutes, 3 minutes remaining. So you have a pill or something knock in the door, 3 minutes remaining, 3 minutes remaining.
هما
Anyone
السنة دي غيروا الكرينال نيرف، خلوه الستيم التاني اللي هو الاير انجري.
examine the ear, you mean?
زي اللي هو في دور ابريل اللي
Okay.
فات ده.
Oh, all right. Actually, we don't have different stem, but if the students say something, so we just make little change. When we make a change about the ear, so we give you the picture of the tympanic membrane and what is in the tympanic membrane. So usually they have hemorrhage in the tympanic membrane due to head injury. So you need to examine facial nerve. You need to examine vestibulocochlear nerve. You need to examine the what is called the equilibrium of the patient. Okay, so you need to examine both facial and vestibulocochlear. And in this station also, we have otoscopes. You need to examine the ear. To examine the ear, you push it up and they have a cone and they have a light. So you can looking, of course, it is normal ear, normal tympanic membrane. But in the picture, you have bulge of the tympanic membrane because the patient have hemorrhage. So you examine the ear, examine facial, examine vestibulocochlear. All right. Anything else you need to examine, Dr. Salah, Muhammad Salah?
لا، هو ده بس اللي قالوا عليه الزملاء، مفيش حاجة تانية. هو
All
فعلا
right.
جابوا له صورة
Okay.
الهيماتيمبانيوم، وسألوهم على ازاي بتحط الاوتوسكوب فقط كده.
Yes. It is important to do it. So don't tell the patient, ask you how to do it. It is important, automatic. It is important to be good observer. In exam, you have a table. Everything in the table, you must use it. So you go to this station, you find the picture of what is called middle ear or tympanic membrane. You found otoscope. You need to examine the facial. You need to examine vestibulocochlear. I show you in the equilibrium now. Okay. After that, how to examine cerebellum. In the past, you have this station separate. To examine the cerebellum, you need to first ask the patient to have a gait. So the gait of the patient. After that, we have 1, 2, 3, 4, 5 tests. First test is romping test. Romping test, you ask the patient to stand, of course, not like this, and you support the patient, don't fail, close his eye, and he is not steady, so we call it romping sign or romping test. After that, nose to nose or finger to nose or finger to finger for coordination. After that, shin or heel to shin. So ask the patient usually have a short, usually male, and you just this heel from the left leg, come to the right leg from heel to shin, so shin of tibia, of course. After that, you ask what is called this diatokinesia, so that rapid movement. Okay, so all this is a gait, romping test, finger to finger or finger to nose, this diatokinesia, and the heel to shin. So just 4 tests. Of course, if the patient of the middle ear or the ear problem, just do romping test only. You just ask the patient to stand, close his eye, and he is difficult. Of course, in the ear, I forget it. You have a tuning fork. I forget in the cranial nerve. Sorry, I think I put it, but I don't found it or what. It is important to use the tuning fork. I don't have it or what. It's supposed to be here. Okay, maybe I missed. I will add it. So it is important, of course. You have a tuning fork. It is important in the cranial nerve. I forget to tell you. And it is important in examining of the ear. So you have the tuning fork. You make the tuning fork. And it is the rule that air conduction is better than bone conduction. So we put first in the mastoid. The patient say, I don't hear now. So you put it in the front of the ear. Yes, I hear now. What is the mistake of the student? Because maybe it's not common use tuning fork. When you make the tuning fork, you held it from the stem here. If you hold it from the tube here, the vibration come in your body. so you don't feel anything. So you make it like this and put it here. After that, the same fork, you don't make it again, put it here, and again you hold it from here, not from the two limb. So air conduction is better. So if you come to examine the ear, so you make tunic fork, you make equilibrium, you examine the ear, and you make rumping test, and looking for the picture of the tympanic membrane bulge or hemorrhage. Okay. Some students, they have whisper tests. They ask the patient 30-30 or something. If it is examine the ear, you can do it. You have a time. But if it is examination of whole cranial nerve, don't do it because you lost the time and it's not much important. Is anyone attend examine the cranial nerve in exam before? Anyone have it?
Yes.
So you managed to go to tell the hypoglossal and examine, ask you some question or no question?
Yes.
Okay. So it is the time is okay.
Yes, the time is okay.
So
But I think I missed the mini mental state.
all right. No, you don't miss it.
I think I
Okay.
missed.
No, you don't miss it. You know that if you tell the mini mental state, you miss a mark. You understand what I mean?
No.
We have mark for something called professional.
Okay.
You do something extra or something unnecessary, this professional is out of 5. So if you make many mental states, they give you 0 for 5. Why?
I
Why
don't
you
know.
need to do many mental states?
There's a stem in cranial nerves which the patient has. I think an anterior cerebral tumor. I think.
Okay.
So I need to test
What is the task? Is do many mental state or examine cranial nerve?
cranial nerve.
If your statement is examine the cranial nerve and do many mental state, you lose mark.
Okay.
So you are lucky you don't lose mark in exam. So don't be so clever. In your surgical practice, you do it as a routine, many mental state.
No.
If you don't do as your routine, so it is not routine in exam. But in sometimes, when the student become more familiar for examining the cranial nerve, we put it just to know how to manage the time. But it is not part from examination of cranial nerve. It is not part at all. If we need to do that, we ask you directly, can you do, like if you see the instruction here, if you go to the first station, first stem, whatever is written, so they write physical examination, no history taken, communication is limited. So is your communication is limited. So how to do many mental state and the communication is limited. Okay. Although all students do like this, examine the many mental state, and the examiner not interrupt them. If any one of the examiner ask you to do many mental state,
No.
okay. If any examiner tell you why you don't do many mental state, I think no. Also, is the student who did many mental state, what is the impression of examiner? He missed the question because you have a question. They have a time to take a question or not?
No, there is no time for taking a question.
Okay, so what question do you ask you in the exam?
It's not. It's examine the cranial nerve, but the question was not related to the mini mental. My cranial nerve station.
What is what is called? What is the question asked by examiner for you?
About the mini mental?
No, you finish the cranial nerve.
Yes.
So after that, he asks you. You have a time to ask some question.
No.
All right. You have the bell of 6 minutes remaining.
Yes.
6 minutes remaining.
I was lucky. Yeah. At the end of my hypoglossal, the bell is ring.
Okay. So the bell is ring. You mean that have 3 minutes, or bell is ring? You finish 9 minutes.
No. 3 minutes. I still have 3 minutes for questions.
Okay. So what is the examiner ask you in this 3 minutes?
No, he asked me questions related to the scenario. What's your diagnosis? Like questions they have discussed with
Okay.
us.
All right. If you waste these 3 minutes for many mental state and he don't ask you the question, what mark you take for the question is 0.
0.
This is why we have usually in exam we say it is easy to fail and it is easy to pass. We don't ask you to do many mental state. If you do extra work, you lose the time. If you lose the time, so you lose some question, so you don't have the exam question or examiner question. This examiner question about five mark or 6 mark, so you lose a 6 mark simply because you waste the time for nothing is unnecessary. Okay, this is station is tricky because whatever I say, the student insisted to do many mental states. So this is why we have this, we happy with this station for long time. Okay. All right. So you agree now, you are now no, you are good that you don't make the many mental state or you still blame yourself?
No, I'm fine, Dr. Shree.
Okay. Because usually the students, they give this impression, so you will be unhappy for that. So don't worry. But if you do extra, the examiner not ask you, stop, they leave you. Okay. After that, we go to examine the abdomen. Of course,
Doctor,
yes. Any question?
in STEM 2 ear examination,
Yes.
when I discover hemotympanum or ear affection, do I do the test of equilibrium right after the ear examination or the end of cranial nerve examination?
What you mean by cranial nerve examination? Which cranial nerve you examine?
I did examination of vestibulocochlear nerve.
You know how to do vestibulocochlear examination? What you mean?
I did vestibulocochlear examination, and the patient had conductive hearing loss.
So you put a tunic fork and you have conductive hearing loss. Okay. After that?
Yes. After that, I am recognizing I am in STEM 2. Do I test a Romberg test right after ear examination?
No, up to you. Whatever. You make it before, you make it after, no problem. It is according to the patient situation. So you start, you finish facial first and tunic fork.
Yes.
Okay, so you can make rhombic test. After that, you go to examine the ear, no problem. It's not a matter. This is very small station. They take about 5 minutes.
Yes.
So it is not a matter you make this before this or this before this is not much different. We make some station easy just to be relaxed because of the stress of exam. Examine the abdomen. Examine the abdomen is fixed station. Of course, in some centers they have examined the hernia, difficult to have a hernia, so they just examine the abdomen. Usually patient have no finding. And again, examination the abdomen is inspection, palpation, percussion, auscultation. Of course, to examine the abdomen, you need to start by general examination. So usually the statement, they tell you examine or do general abdominal examination. We give you any scenario, epigastric pain, right iliac fossa pain, right hypochondrial pain, whatever. Usually the patient is normal, not in pain, and you started by inspection. It is important to look that you must stand in the right side. Okay. We don't have code now. So inspection, palpation, percussion, auscultation. We don't do digital rectal examination. Before do that, I just go to that, but before you start, what you need to do general examination. Suppose you forget to do general examination, so the examiner asks you, are you forget to do general examination? No, doctor, I make it at the end, just to save your time or to save your mark. Of course, you forget it. So general examination started by eye, mouth, gynecomastia in male patient, looking for the hand, looking for lower limb edema. Usually, besides the patient, they have vital sign chart, which is now we call it news chart. So you can look in for pulse, temperature, blood pressure, just to save the time. We don't need to measure all this. So don't forget to examine the eye, mouth, the neck, chest, lower limb, and of course the head. All right. In abdominal, it's better to do flapping tremor for liver disease. And of course, when you look into the eye, looking for jaundice, tinge of jaundice, mouth if they have stomatitis or hypovitaminosis, any dental caries, neck looking for the supraclavicular lymph node or neck veins, chest looking for spider nevi and gynecomastia, lower limb looking for lower limb edema and the level of edema. Okay. After that, straightforward to inspection. Inspection usually done from the bed and from the side. From the bed, looking for the contour, no dilated vein, umbilicus in position, no fullness. Maybe the patient is overweight, so you have some sort of distension, normal hair distribution. Go to the side. When you go to the side, you are looking for what is important in UK. What you looking for? Inspection from the side. Anyone? You go to the right side of the patient, looking to the patient abdomen, looking for okay, looking for epigastric pulsation. Epigastric pulsation in England mimic abdominal aortic aneurysm. Of course, you don't found epigastric pulsation, but if the examiners tell you, suppose you found epigastric pulsation, how to confirm it is abdominal aortic aneurysm or transmitted pulsation, just put your hand like this, not like this, like this. You can find it's moving up, so it is aortic aneurysm, not moving much, so it is transmitted pulsation in same person. You feel aorta and epigastrium only an aortic aneurysm. Normal aorta, you feel it left to the umbilicus level of the lumbar 4. So inspection. After that, you go to palpation. The idea of palpation must be your hand and the forearm in the same level. So according your height. So not necessary to stay in chair or become shorter or something. It is according to the situation. Usually you have a chair, you can sit in the chair, or you can stay in your knee, whatever, but the arm and the forearm must be in the same level. You ask the patient, inspired, expired. Of course, you start the palpation by superficial palpation, then deep palpation, then palpate the organ. Okay? So if the patient say, I have pain, I try to be gentle, and after that, you palpate the liver from the right side, you palpate the spleen from the right side to the left side. Don't forget to palpate the kidney. So liver, spleen, the kidney. After that, inspection, palpation, percussion from the middle, and after that, auscultation. So palpation of the liver like this. You can measure the liver span if it is enlarged. You percuss from up, from second intercostal space down. Usually it's not palpable. Sometimes the left lobe is palpable. People base the spleen from right side. If it is small spleen, you can ask the patient to tilt it to the left side. Kidney by manual, looking for ballotment. After that, percussion. After that, auscultation. To complete your examination, someone, Dr. Asma asked, just a minute. Examination from the end of the bed. We expose the patient before or don't expose him except you start from the side. No, if you inspect from the bed, you expose the patient. But of course, we don't need to expose the genitalia, because if you need to expose the genitalia, you can just look and ask the patient to cough in the male patient. But we don't make it neck to the mid of the thigh, like the traditional way. So you expose the patient, you start a general examination, the patient is not exposed. After that, you expose the patient and go to the bed, the end of the bed, and after that, the side of the bed. So inspection, palpation, percussion, auscultation. So don't be so clever, because we can find some students say, I'm looking for renal artery stenosis. It is impossible to diagnose renal artery stenosis by this cystoscope. It is impossible to diagnose what we called it venous hump in the liver due to portal hypertension, what we called it Ma'mun sign. So just to say it is normal intestinal sound, that's enough. So don't be so clever. So inspection, palpation, percussion. It is important to know that the examination of the back is part of examination of the abdomen. So it is important to ask the patient to sit down looking for his back. Okay. In some country, you can find, like in Malaysia, you can find the patient have what is called traditional cup therapy. It is something like circles. It is like some traditional use air or heat. This is called cupping. All right.
Gamma.
Yes. So it is important to mention that if you have it. Okay, so don't forget inspection, palpation, percussion, examine the back, examine the genitalia. Simply don't expose the patient, ask him to cough, and stay in the right side. Inspection from the bed and from the side. From the side, looking for aortic aneurysm. So that's it for all the abdomen. Usually, if he need to make some scenario, so he can ask you, can do Murphy sign. So Murphy sign, of course, you put in the lateral border of rectus abdominis below the costal margin. Ask the patient to take inspiration, expiration. The patient hold it. So it is Murphy sign for acute cholecystitis. Or he can have tender McBurney if mimic acute appendicitis. Okay. Usually do that, usually not what you will do later, investigation. Of course, the patient is normal. You can do abdominal ultrasound, baseline investigation, something like that. So this is easy stations.
Dr. Shireen,
Yes.
if patient or the scenario is with appendicitis or diverticulitis or even cholecystitis,
Yes.
we start the palpation both the site of let's say appendicitis,
Yes.
or typical examination
No,
and
no.
skip
This is
the area.
exam. This exam is a typical examination. And after that, you can do tender McBurney or the other specific for appendix, can. But this station is how to examine the abdomen in traditional way. It is not, we have something called focal abdominal examination. If we need to examine for acute cholecystitis or acute appendicitis, so we tell you can do focal abdominal examination for acute appendicitis. You know the idea.
Yeah.
Yes, so it is means that you make tender McBurney, you make rebound, you make Rovsing sign, you make obturator internus test, you make psoas spasm. Five sign: tender McBurney, rebound tender, Rovsing sign, obturator internus test, and psoas spasm. But this is the station is examine the abdomen. Okay. Is anyone have a station of the abdomen before? What happened in your station? Any sum is difficult or different, just tell me. Okay. After that, what we
Doctor,
have, yes.
you said there is no need to be at the same level for the patient. We can examine the patient while we are standing
No,
behind.
it is, what is the idea? The idea is your arm and the forearm is the same level. Don't do like
even
that.
we are standing.
It is according the level of the bed and according your height. You understand? It's not need to
Yes,
kneel.
yes.
Don't need to be down. Suppose you are, because some bed is high. In England, the bed can be elevated up and down. So it is according your height. Suppose you are very tall, So we have a chair beside you, or you can like this. But the idea is not kneeling. The idea is the upper arm, the hand, and the arm in the same level. You got the point, like this.
Yes.
Don't make like
Yes.
this. All right.
Mm.
So it is like
Yes.
this.
Yes.
Okay. So if you are shorter, longer, so it's different from one to one. Okay. So take it easy. Don't worry.
Dr. Shireen,
Yes.
jaundice with abdominal examination,
Yes.
is it frequent or
No, it is
no patient?
mandatory station because what we have, you have 3 station now. You have head and neck, you have vascular, you have orthopedic, and you have abdomen. So orthopedic must come, abdomen must come, submandibular or cranial, one of them can come, both can come. So it is according. But what is the force? You mean that it is common or not common? It is common because it is easy. Okay.
And crisp station, not abdominal examination.
Actually, critical care, you mean critical care station is not abdominal station simply because the examiner is not a surgeon. So what is the examiner examine you? For example, what examiner examine you in pathology?
Pathology for reporting.
No, it is pathology. In the
Pathology.
basic science, the college basic science is a basic scientist. So who is
Yes.
examining you in critical care? What is his specialty?
General medicine?
Say again?
General medicine?
No, it is either anesthesia or physiology. It is critical care is under physiology. Critical care, intensive care is under physiology. In exam, in the knowledge, you have 3 station anatomy, 2 station pathology, 3 station physiology, 2 interpretation of data, and 1 critical care. It is critical care, is not necessary to be critical ill surgical patient. So the examiner here is one of 3, either anesthesia, intensive care, or physiology. So this is impossible to be examine the abdomen. So this is why if you touch the abdomen, the patient say it is hurt, don't examine. Because this is not under surgery. It is in the knowledge and the examiner is not a surgeon.
Yes.
Okay, it is important to know that in some country like Southeast Asia and Europe, the doctor of physiology is not graduated from medical school. It is graduated from the what's called College of Science. So it's not medical practice. You know that or not?
No, I don't know.
Okay, so the people who teach physiology in all over, even in Malaysia and most of the country, is not medical, not like in Egypt. It is graduated from the School of Science. Okay, so it is not at all examination. You can examine the chest. It is like, suppose you are anesthesia and seeing the patient. So anesthetist, when sees the patient, he take quick history about smoking and all this, and he examines the chest and look for the investigation. So this station is mimic what the anesthesia or what we call the pre-admission clinic in UK. Okay, you enter this station before and examine the abdomen, or what happened?
No, I didn't enter crisp station. I'm just
Yes,
curious.
most of the student examine the abdomen. We don't need to examine the abdomen. Is the logic to examine the chest? The logic to looking for investigation? The logic is to ask the patient about smoking, about bronchial asthma, about dyspnea, and all this. All right.
Right.
So again, under knowledge is not clinical examination station, although you can examine the chest or the heart, but it is not under clinical station.
Yes.
And the score is different and the mark is different. Okay, now we back to what is called vascular. Of course, the vascular is very important. And whatever the station of the vascular, you need to know how to use handheld Doppler. Okay? So, for example, give you scenario, whatever the age. Of course, the age is different according to the actor. So, 65 years old man is seen in outpatient clinic, pain in the left lower limb after walking. Examine the patient. Examiner ask you some question. Once you have examined, examiner ask you means that 6 minutes for examination, 3 minutes to discuss with examiner. If you take the all time for examination, you lost few mark for question. Okay. So it is important in anything bilateral, like hand, like breast, like thigh, like lower limb, you need to expose both. The same in orthopedic, you need to expose both. By inspection, looking for the skin color, loss of hair, very important sign of ischemia, any wound or ulcer, any infection between toes, so you need to examine between toes, any muscle atrophy. After that, you need to test the sensation by piece of cotton, not by needle. Of course, we don't have needle in exam. You can see the temperature by your hand, and after that, looking for the pulse. Of course, it's better to use handheld Doppler. So looking for the leg, for example, you can find some discolor. We call it lipodermatosclerosis due to venous hypertension. These patients have no loss of hair. They have brittle nail, no fungus infection between toes, no wound, no ulcer, something like this. Or very pale, and you put your hand, it's very cold, loss of hair, so it is ischemia. Okay? After that, you have handheld Doppler. So need to know how to use handheld Doppler. We have on and off and have volume, and put in dorsalis pedis, put in posterior tibial, not necessary to put in popliteal, difficult, put in femoral. Of course, you start from distal to up. Of course, if it is dorsalis pedis, posterior tibial is present, no need to be further examined. Okay? So you examine by inspection, examine the skin, wound, loss of hair between toes, brittle nail, if any hyperpigmentation, lipodermatosclerosis. After that, go to pulsation. Of course, before that, the temperature, pulsation, you put it here. You can better start to see the pulsation or palpate the pulsation by handheld Doppler. Okay. After that, the examiner asks you some question. I just see one question, examination of the endonode. Do you have to start face carotid femoral? I don't know the word is glabellar. Dr. Hoda, what you mean by glabellar after that face carotid femoral? What you mean? Hoda, okay. General, yes. Okay, no, here we don't need to have general. And you don't need to start from the face. It is just the lower limb, so you start from the lower limb. Okay, except if the patient they mention they have generalized disease like renal phenomena or something, and it is very rare. So it is just to examine the lower limb. So you don't need to do general examination. Okay, and someone is also asked about ankle brachial index. Okay, so you have inspection, you have palpation, you go to for that. So what is logic to do? You can do Berger test. Berger test, you elevate the leg, you're looking for the sole. If it is red, make it down, become pale first, and become more red. Okay. You can try to do ankle brachial index, but don't use the stethoscope, use the handheld Doppler. So either the examiner asks you to continuous or they stop you. How to use the Doppler? How to use the Doppler? I show you the picture. Okay. So in the history, just a minute. I show you the picture. Okay. Just to give me a second, looking for the picture of Doppler. I just share with you the picture. It is from the internet. I don't found my picture. Okay. You can see this in the middle. This is the common, what we use is the handheld Doppler. This one. Okay. You have gel. It is not a KY. It is the ultrasound gel. You have a probe. You have here on and off button, and you have volume beside. So just make it open. You can try in your hand first. After that, put in the patient. So again, just to be easy, what you will do, I just back again here. So what you will do first, you can put in the piece of gauze some gel. This gel is not KY, it is ultrasound gel. And you make it on, increase the volume, put some gel, put in your hand. If it is work in your hand, so it's okay. We make a sound. After that, you start to put in the patient. So this is how to use handheld Doppler. Handheld Doppler is very, very important in exam. You must use it in exam. Okay. After that, of course, you start by dorsal pedis, posterior tibial. If everything is okay, no need to go to up. If you need to go to up, it's better to go to femoral, not popliteal. You can do Berger test, it's okay. You can start to do ankle brachial index, put the stethoscope, but not the stethoscope, the sphygmomanometer in the upper limb, because ankle brachial, so the ankle first, but you can make brachial first. And looking the same way you measure the blood pressure, and you can enlarge it. And when you see the first one, so it is the systolic, so it is the systolic, make it in the lower limb. So you have ankle brachial. So if it is in lower limb 120 and upper limb 120, so it is 1, so it is correct. Someone asked how to Doppler. No, how start pulse examination from distal or proximal? Of course, it is the logic is distal, not proximal, because distal is if the patient have ischemia, start distal, and if patient below the limb is not have femoral artery occlusion, usually it is the occlusion in the lower part of femoral. The common site of occlusion is the end of femoral artery, beginning of popliteal artery in the adductor canal. So you start from distal, not from proximal. Okay. For teaching, you can start anyway, but for exam or for the practice, you start distal up. Okay. All right. So now you have inspection, you have palpation, you have everything. After that, just a minute. Okay. So you start by inspection. Again, you're looking for the skin, loss of hair, any wound, infection between toes, muscle atrophy, sensation by cotton, temperature by your hand, start to see the pulse by handheld Doppler, and after that, the patient is normal. So he give you impression, like suppose the patient have no pulse in dorsal pedis, what you expected can be limb ischemia. So how to confirm? Apart from baseline investigation, I can make handheld Doppler. Also, I don't feel, I make a duplex. And after that, is better to have an angio. So he show you the angio, something like this. Is bigger here. So if you see this here, You can find cut off here, end of femoral, which is common, beginning of popliteal. But these patients have no sign of ischemia. It is just relative ischemia. You know why this patient is not ischemic? What you think? Anyone?
Thrombosis.
No. He's thrombosis or embolus, but the patient, his limb is
Collateral.
viable.
Collaterals.
Collaterals. Oh.
Yeah, but this patient is lucky, have a good collateral. It is very rare, but have good collateral. This is chronic ischemia. Yes. But at least you need to remove this embolus by embolectomy, balloon dilatation, and you can put a stent. In the past, we don't put a stent down because the movement of the knee. Nowadays, with the technology, with the improvement of the technique of the graft, you can put the graft anywhere. Okay? So what you will do for this patient, so embolectomy, balloon dilatation, and after that, I put a stent. All right? Lower limb ischemia is very common, and usually the patient have no ischemia, but maybe have a picture like this. Okay? It is important, don't forget to stay in the right side of the patient, not left side like this, doctor. Okay. After that, we have what? I think someone asked, so yes, he said colonic ischemia. Okay.
في من فضل حضرتك if the angio showing long segment, missing segment,
Yes.
for management, we will say like grafting or bypass, and in
Are you
short
vascular
segment,
surgeon or what?
general surgeon.
General surgeon. Nowadays, no one do grafting or bypass grafting. In the past, we do bypass grafting. If you are 20 years ago, we have saphenous vein grafting and elevated and make it reverse. After that, Gordex and other grafting. Nowadays, everything, even for aorta, even for thoracic aorta, done by endostent or new stent, metallic stent and other. In the past, we have restriction like long segment, like below knee, something like that. So if you read from all the book, he say if they have long segment, you need to have bypass surgery. That is your opinion?
My knowledge like that.
Okay. So suppose it is what is more serious or more complicated is the aortic injury, aortic artery, aortic aneurysm or femoral artery aneurysm. Is more long segment or more bigger or more wider is aorta or femoral?
Aortic.
So what we do now in aorta?
Endostenting.
Endostenting. If we make it in aorta, and even in aorta, maybe sometimes it's difficult to remove the stent through the grafting because this is what is called the EVAR or endovascular stenting. So it is not easy because the big thrombus. So if you compare aorta to femoral, is no way of comparison. So it's not a matter now to say it is long segment or all this. Okay?
Okay.
So now everything done by endovascular or stenting or all this is become something very common. Of course, maybe in Egypt they have some lack or some country is not so common, but you know that it is English exam, so most of the technology is present. Okay.
Thank you.
All right, you are welcome. Now we have varicose veins. I just bring varicose vein because last time one of the students he complained, and after he complained, they asked me to contact him. When I contact him, he say, I have the script like this. 55 years old woman working as a chef in a restaurant. You know, chef usually is long standing. It's common in some country. Complain of the dilated vein in the lower limbs. So examine the vein or examine the patient. So mean examine the varicose vein. Okay. So the candidate enters the station and he asked, he looked into the patient. He found that the patient have a plaster in the saphenofemoral area and have multiple stair strip. Stair strip is the small strips in the below. This is by inspection. And he asks the examiner, can I have tourniquet to do tourniquet test? So the examiner say no, no need. So why the examiner say no need?
It's post-operative.
Yeah, this patient is post-operative. So classical, if you need to do saphenofemoral disconnection or Trend-Berg test, this patient is already have saphenofemoral disconnection, which is Trend-Berg operation. So to test the saphenofemoral junction competent or incompetent is not a matter because they don't have. So this patient have a stripping till the knee, which is common done nowadays, followed by multiple avulsion below the knee. So what is the logic? He say, I found blister in the upper part of the thigh, and this patient is already had varicose veins. So the most probably they have saphenofemoral disconnection, and they have multiple avulsion with covered by stair strip below knee. So this patient already remove the long saphenous. Looking to short saphenous, may be dilated, not dilated. Looking for the other hand, may be dilated, not dilated. But because the student, he found that the examiner said, we don't give you tourniquet, he say it is not a varicose vein, so something, and he start to examine the knee. We don't know why, but he think that it is maybe knee examination because yesterday they have knee examination. Of course, it is not knee examination. So sometimes when we arrange the exam, we ask for a case normal or a case for varicose veins. So is already they consider the patient as normal because the patient is operated. So what you will do, first introduce yourself and look into the venous system. Can be long saphenous, can be short saphenous. Okay, so this is easy. So this is long saphenous. So long tortuous dilated vein or normal vein, which is the common. Or in the other side, so short saphenous. After that, looking down, so the patient have hyperpigmentation due to venous hypertension, so it is lipodermatosclerosis, or the patient have an ulcer. So you found the ulcer, you can describe the ulcer, like site, size, shape, and of course the edge is sloping, and this red color, so not granulation tissue, not infected. Skin around is have some sort of pigmentation due to venous hypertension and some deformity in the finger, in the toes. Or lipodermatosclerosis due to venous hypertension. Okay, this is handheld Doppler. We back again. So first, you're looking for which venous system, long or short saphenous. After that, skin complication, like pigmentation or ulcer or pallor. Palpation. So sometimes they have tender in the site of the vein due to superficial thrombophlebitis. It is important in examining any limb also to test the arterial pulsation, maybe associating ischemia. This is the handheld Doppler again. It is good. So this is the typical you see in exam. So this is probe. This is usually on and off. Volume is inside. And this is a gel. And you just use it to confirm the pulsation. So if the patient have ulcer or have varicose veins, so if it is like make bad vigorment or disfigurement, so it's better to remove it. What we will do nowadays, saphenofemoral disconnection, stripping till the knee, followed by multiple avulsion below the knee. So why we do multiple avulsion below the knee? Because we have the saphenous nerve, which is branch of femoral, is come in this area, so can cause loss of sensation in the area of big toe. So this is now in the past, we do stripping from above till down. Nowadays, from above till the mid, till the knee, and after that, multiple avulsion technique. If the patient have ulcer, so frequent dressing, we called it 4-layer bandage. The first layer must be non-adherent. Okay. The same for lipodermatosclerosis. Usually in black races, maybe have varicose vein is not apparent or not easy to say it. So just daily dressing, antibiotic when infected, and compression bandage. Okay. Again, this is what we did, stripping till the knee. After that, for this, we do multiple avulsion. Multiple avulsion, this is the same patient. Just make a hole here, and push the veins like this. You know, that make a hole here, and push the vein, avulse the vein. And can put a strip or suture, and after that, bandage and elevate the leg to avoid this ecchymosis and the bleeding. Okay? So this is why we don't do stripping now, because afraid from saphenous nerve dermatome or affection of saphenous nerve. Okay. So again, if you do stripping till the knee, after that multiple avulsion. Okay. I think now this is all apart from orthopedic. I just to confirm again if something missed. Okay. All right. So for the doctor who asked about critical care, I just show him the station. This is the last. For the what is called orthopedic, in the my YouTube channel, they can found done by Prof. Arshad. He's an orthopedic examiner in Republic of Ireland. So it's better to see it in my YouTube channel. You have a patient and how to examine in the real patient. Okay, some have a question. Fistula examination. Okay, I forget. All right. So fistula also is common. So to examine the fistula, in the past to have a real patient, now sometimes they have drawing in the arm. So if you examine the fistula, started by inspection. So by inspection, I have a swelling 5 by 7 centimeter, versatile, have mark for puncture or the needle, and after that, this is an inspection. You examine the distal, like if it is here, examine the distal part. So no pallor distal, no parietal nail, no loss of hair, or have parietal nail or loss of hair. After that, you go to palpation. The palpation, of course, after introduce yourself, clean your hand, put your hand over the swelling so you can find a thrill. After that, you examine the distal to this. So you examine for distal pulsation, because sometimes they have weak distal pulsation, what we call it steel phenomenon. You're looking for the pallor distally. You're looking for loss of hair. After that, you can have, you put a stethoscope, you feel machinery murmur. So the examiner usually ask you, what is the complication of EV fistula? What is the indication? It is for dialysis, chronic renal failure, so the patient dependent on dialysis. Complication can be rupture, can be obstructed, can be infected, can be affected distally, what can cause ischemia distal of this. So what is precaution? Do it before we do something called Allen test. Allen test to see what is dominant artery, is ulnar or radial, and we use the non-dominant artery. This is anal test. You compress here and compress too, and see in the same time in the hand of the patient before the operation, and see which is dominant artery, use the undominant artery. Okay. Anyone examine in EV fistula before? I just need to confirm that in your country it is used real patient. In the past we use a real patient, but I heard that they have a normal patient and they make something mimic it, like makeup or moulage or drawing. So it is mimic the EV fistula. Okay. So no much question. Also, it is easy station. Any question till now in general for the what topic we have?
كان عندي بس سؤال في الاير اكزامينيشن. احنا في الطبيعي
say again which
في اثناء
examination
الاير اكزامينيشن في الكرينال نيرف، لما بنحط التانينج فورك العيان بيبقى المفروض ان الستيشن ده عنده هيميتمبانيوم، فعنده البون كوندكشن هيبقى افضل من الاير كوندكشن. فطبعا فانا همسك التانج فورك بقى هعمل اكزامينيشن بالعكس، يعني هحطه الاول قدام ودنه فهيقول لي
no Rene test all the test is done classic way.
يعني on the
So it
mastoid
is after you start first by tunic fork, put it in the mastoid. So I feel. Now I don't feel. You put in the front of the ear, no, nothing, I don't hear. We
okay.
don't have modification of the test because we don't know what is the patient condition. Okay.
يعني
In the real life, the patient not come with the script with him.
In classic, I put the tuning fork on the mastoid until patient tell me I can't hear. Then I put it in the ear. He said me I can hear.
Yes, this is what you do in this test also. If the patient have ear problem like conductive, so he have good bone conduction. And here, after that, he stop bone conduction and don't hear with air conduction because air conduction is better than bone conduction. You get the point or not? You don't modify the test. The test is done, suppose you done in normal patient, normal person.
In normal person, he said to me, yes, I can hear, but in disease, he said to me, I can't hear also.
No, because is the patient in the disease, you mean hear from the bone conduction or air conduction?
In the injury, there is bleeding, so there is no air conduction.
Okay.
In this patient.
You put just one by one. You put it first in the mastoid process.
Okay.
The patient now say, I don't hear. Stop.
Yes.
Okay. After that, you put in front of the ear. He's saying, I don't hear anything. So means that have conductive deafness. That's it.
Yes. جزاكم الله خيرا. تمام.
Okay. It's a simple way.
Okay.
So who doctor ask about critical care? Is still with? Yes. What you need to clarify? What's your name?
Rami.
Okay. So yes, Rami. Yes. So first, so this is the station, the statement of the station. Okay. And you are asked by staff nurse to review a patient. This is the last station, so I finish after that. Who is underwent major abdominal surgery, for example, right hemicolectomy for cancer 10 days ago or 3 days ago, is different from station to station. The patient complained of some intermittent dry chest pain, fever, and abdominal pain. You found patient observation chart available. Your task is to make detailed clinical assessment, and you don't need to discuss finding as you going on. You have been asked by, okay, so you can see here, you asked to review the patient, not examine the abdomen. You find observation chart and investigation, detailed clinical assessment. After 6 minutes, present your finding and discuss. This station is clinical examination, is skill and not history taking. When you see this patient, I go to the end. You can see this abdomen. Where is the patient abdomen? Here is covered or have colostomy bag, whatever. Okay. But you don't touch the patient. If you touch the patient, he said it is painful. I think no need to touch, or the examiner ask you don't touch because it is not abdominal examination station. You understand now?
Yes.
So what you will do in this station? So start first. So this patient, you asked by the staff nurse to review the patient. You have observation chart, you have a patient. So it is like pre-operative or post-operative assessment. So suppose this patient have hip pain or waiting for osteoarthritis or right hemiarthroplasty or whatever, it is not a history taken. Don't analyze the pain or ask about the pain. It is not a communication skill, so don't tell you need a painkiller. It is not a matter here. Here it is evaluation before or after surgery. So it is not history taken, not a communication skill. So you can find actor in the coach with Berselt in his name. Vital sign chart is present, oxygen mask present, stethoscope present, hand gel tissue, wound dressing in the abdomen or colostomy bag. So this is what happened in the station. So you stay on the right side, introduce yourself. This patient usually, when you start, he become make like this. So he gives the impression that, so make that I have shortening of breath. I don't take my breath. So what first thing you make to do?
Oxygen bag.
Say again?
Check the patient is patent airway by telling
No,
his
the
name.
patient speak to you, but he have difficult breathing. Is not a trauma patient.
I will put oxygen mask.
Okay, so you put the oxygen mask. After you put the oxygen mask, what you will do?
I will inspection for.
No, relax, doctor. You know, we describe the real life. In your hospital, you put a mask and
Are you okay now?
no, open the oxygen. If you don't open the oxygen, the patient will die.
Yes.
And adjust the oxygen 3 to 5 meters. After that, put the pulse oximeter. It is the action. So this is the station is the action. So patient make like this. Okay, are you okay? No, I'm not okay. So what I do, I put oxygen mask for you. So this is the oxygen. I connect it. Of course, usually exam in hospital. In some center is not in hospital, so maybe have a trouble. So it may be different, but this is what real exam. After that, put the pulse oximeter. After that, looking for the
measure oxygen
intravenous
at what
fluid.
scale?
Say again.
I set the oxygen at what scale?
3 to 5.
3 to 5.
Anything, but you I don't see anyone move this oxygen. Okay, 3 to 5, maximum 15, anyone, but just to make it oxygen. After that, we close soon just to save oxygen. After that, intravenous fluid is connected. Of course, this cannula is big cannula, so don't wait till the fluid is pass. After that, you're looking for vital chart. Vital chart, you can see have some temperature here, either in the wall like this, or in the footbed like this, according to the hospital facility. So looking for it. So it is the patient have some temperature, blood pressure is low. After that, looking for vital sign chart in detail, maybe some loss of conscious, Glasgow scale, all this. After that, examine the chest. So go to inspection, palpation, percussion, auscultation from front, auscultation from back. After that, the patient is somewhat stable. He becomes stable because he don't make dyspnea all over. So just a quick, mister, you have dyspnea, orthopnea, paroxysmal nocturnal dyspnea, you have history of bronchial asthma, you smoke a lot, you have chest pain before, you are an oral anticoagulant, and you can look into his neck vein, looking for the tongue and hand for cyanosis, and looking for lower limb edema. So it is just quick history. So you manage the patient, you take a quick history. After that, look into the investigation. Look into his arterial blood gases. Can be normal, can be metabolic acidosis. In this patient, it is respiratory alkalosis. Of course, the arterial blood gas is different from center to center. After that, look in ECG, can be normal, can be AF. After that, look into the abdomen, he tell you don't touch, it is painful. After that, the examiner asks you about the arterial blood gases, ask you about ECG, how to manage this patient, and this station is physiology station. After that, if the patient is not necessary, if it's query deep venous thrombosis, so what else you need to examine? I need to do Hoffman sign. I need to examine the calf muscle. All right. If the patient have Hartmann procedure and have a fever, what's your diagnosis? Dr. Rami, if you remember.
I think chest infection, pneumonia, or pulmonary
Okay.
arteritis.
Never to be anastomotic leak because we don't have anastomosis. Although most of the students in Hartmann procedure and in left hemicolectomy, they think that these patients have anastomotic leak. It is impossible to happen simply. If you have left hemicolectomy, you have colostomy before. If you have Hartmann, you don't have anastomosis. So some students believe that this station is anastomotic leak, and actually it is not a stomatic leak at all. And never happened the anastomotic leak. If the patient after 10 days can have deep venous thrombosis complicated by pulmonary embolism. But if it is 3 days, impossible to be deep venous thrombosis and pulmonary embolism because pulmonary embolism take at least 10 days, except if the patient bedridden for longer time before that. Okay? So at the end, he asks you, summarize the finding. What other examination would you wish to perform? I need to examine the calf muscle to exclude deep venous thrombosis. Possible underlying cause, we have two options. If the patient after 3 days, so chest infection, lung atelectasis. 10 days more can be deep venous thrombosis complicated by pulmonary embolism. What's the investigation? Baseline investigation and the D-dimer and chest X-ray and all this. Okay, management is dependent. Chest infection, you have antibiotic, and of course you need to consult the what's called the medicine or the chest physician. Can be anastomotic leak? Impossible. Never to be anastomotic leak. Okay. So this station, Dr. Rami, if you ask about this station, is not clinical examination, not abdominal examination. It is examination of the cyst under physiology as a part from preparation of patient for surgery or post-operative evaluation of the patient, and usually done by the junior doctor or done by anesthesia. Okay? And again, it is not critical ill surgical patient. It's not CRISP station. It's not I need to move to the CRISP protocol simply because the definition again of the critical ill patient is, I think I have it here. Okay. Critical ill surgical patient is defined as someone experiencing life-threatening condition caused by surgical procedure or complication of surgery, require intensive care, monitor to support vital organ function, prevent the vessel deterioration. Typical involve patient with multiple organ dysfunction, high risk of imminent death. So the usually critical ill surgical patient must have at least one organ failure. So if you need, of course, it is the same. So whatever critical or CRISP or ATLS, all are the same. You're looking for airway, breathing, circulation. But of course, in this station, you need to have an action. So this action, you put a mask, you open oxygen, put the pulse oximeter. In some center, like I think is done in college, not in hospital, so maybe have no this facility, so they make some modification. But most of the exam all over the world is done in hospital, so they have oxygen over bed, they have all facility, they have everything. Okay. I hope that yes.
Dr. First, this instruction for all patients with critical care, with critical ill patient. The stem of the stem.
No, it is a stem. It can be different, but the students think that all surgical patient is critical ill surgical patient. It's not all surgical patient is critical ill surgical patient. But the treatment can be the same because you're looking for the airway, you're looking for the breathing, you give intravenous fluid. But it is not necessary to say now I shift to the CRISP protocol because it is not necessary. It's not a critical ill surgical patient. But you can tell
Okay.
it, no problem. We don't have a mark for this.
Yes, we didn't start by general examination from the footbed. We start already by support by
No, this is not a
give
clinical
patient oxygen.
examination station. This is patient like in critical situation, have shortening of breath, you need to save his life. So it is you give oxygen, you see the pulse oximeter. What you need to start first? You need to examine like what? Like abdominal
No,
examination?
but
What?
all topics said we must start first. We start by general examination, even abdominal or chest examination, and when we
Yes,
start
but this
to
patient
do
will
local.
die. You know, if you start by chest examination, the patient make like this. So if you need to give oxygen or not to give oxygen. So you give oxygen and start, okay. But if you don't give oxygen, don't put pulse oximeter, don't open the oxygen, you will be lost.
So when we admit to the patient starts to complain of dyspnea, and we already start the
Put the
steps of
oxygen
this.
mask. Yes, I think is anyone attend this station before? Maybe give her good idea. It is very common, and this is very common station. And some students stuck just to make chest infection and stop. Some students make abdominal examination and stop. So this is why we advise the patient don't ask him to touch your abdomen. It is not a clinical examination station. Okay?
Yes.
It is.
When we examine the chest, we examine the expansion, percussion, and auscultation from back also.
You examine in the quick as soon as possible because you have a lot to do. You need to take quick history. You need to manage the patient. You need to examine the chest. You need to have a look on arterial blood gases and the ECG. So it is time management is very critical. So you need to don't waste your time for something unnecessary. Just inspection from front, palpation, percussion from front. Auscultation can be done from front and back.
Okay, the revision of chart of the patient.
Yes.
Both
Just looking
any
for temperature because the chart is especially what is called the new chart is have a lot of data like this. But what is important for you now, looking for fever. Okay, you're looking for fever, you're looking for blood pressure. That is important. Class coma scale, pain score, all this is not important now. Respiratory rate, all this is not important.
Okay, we don't ask the examiner to give sphygmometer and stethoscope to measure the blood pressure. No need to count the respiratory rate.
If anything, you know that first we put the what is called adjust to make it bigger. We put the chart here. If we put a chart, so you don't need to do that because it is not important. We don't test you how to measure the blood pressure.
Mm.
If you do, we don't have a sphygmomanometer, but if you ask the examiner, he don't bring it to you, of course. He say, okay, consider done. Because you must read. You know that if you are consultant or senior, he's just looking for the data. This is vital sign can be done by the nurse. So don't waste your time. You know that to pass in the exam or fail exam is how to manage the time. If you manage the time, okay, it's easy.
Yes,
Yeah.
yes.
All right. Thank you.
Okay.